reboot. I've lost the program. Just love IT. But my first item on the program is actually Melanie, who's going to tell us about the Jennerosity event and what it means and how we can raise lots of money through it. Over to you, Melanie.
Yes, so thank you, Derek. Yes, some of our speakers are on holiday, so we had to have pre-recorded talks just for info, just a few of them. And for all our visitors, just to let so Jennerosity is the infection and immunity fundraising event. And that's we have it annually, and every day we choose, every year we choose a different charity that is closely aligned to our research work. And this year we've chosen St. George's Coronavirus Action Fund. And I'm really pleased to say that we've already had donations up to £1,000 with gift aid. And so I want to thank all those who have donated and everyone who has supported this event, as well as all of you for joining us today. So thank you. So over to Derek.
Thank you, Melanie. So it remains for me to introduce the first talk. And I think Audrey's going to press the button on that. Is that right, Audrey?
That's correct, yeah.
Oh, good. Okay. And the first talk is Heather Blackhall, who's going to talk to us about the Coronavirus Action Fund. So over to Heather.
Okay, let's try this.
And a campaign officer for the St. George's Coronavirus.
Excellent.
Okay.
I'm Heather Blackhall, the Alumni Engagement Officer at St. George's and a campaign officer for the St. George's Coronavirus Action Fund. The fund was launched in May this year to develop our specialist research environment and help our researchers to respond to the current emergency. It provides funding to help develop our facilities so that they can carry out essential research into the immunology, virology and genetics of coronavirus. Through the Coronavirus Action Fund, we're helping our scientists to make vital progress in understanding and responding to the disease. St. George's University of London is uniquely placed to deal with the current crisis, and our cohesive relationship with St. George's Hospital and our shared site means that clinicians and academics are able to work in partnership to pursue applied and translational research. In May, we were really proud to hear that St. George's University of London and St. George's University Hospital's NHS Foundation Trust were leading the country for urgent public health studies into coronavirus, according to data from the National Institute for Health Research. We were also pleased to see that the launch of our fund was featured in online news outlets such as My London and London Higher, and many of our researchers have appeared in local and national media, sharing their knowledge and expertise on the virus. Our teams have been involved in studies of national importance, for example, the groundbreaking Oxford University-led recovery trial, which will revolutionise how we treat COVID-19 through the recent discovery of the life-saving effects of dexamethasone. I know that you'll also be hearing from a few more of our researchers today on their own projects and how they are helping influence our response to the disease. Since the launch of the Coronavirus Action Fund, we have had a great response from our alumni, staff and external supporters wishing to support our cause. We've received £8,000 in donations so far, and that's enough to purchase some of the essential equipment required in many different diagnostic and research protocols, as well as supporting one Category 3 laboratory with consumables and personal protective equipment for a month. We aim to increase this figure in the coming months in order to be able to support more of the many worthwhile coronavirus research projects taking place all across the university. Finally, I would just like to say that we are so grateful to all of you for your own involvement in fundraising for our Coronavirus Action Fund. Your support is really appreciated, and the money raised through Jennerosity will go a really long way in helping equip our laboratories for coronavirus research and in helping our researchers inform policy and practice in the COVID-19 response. Thank you for the part that you've played in supporting groundbreaking research to tackle this devastating disease and shape a healthier future when we emerge from this pandemic. I hope you've enjoyed hearing a bit more from me about the fund, and if you have any questions about anything to do with the Coronavirus Action Fund, please email us at covid@sgul.ac.uk. Thank you.
Great, thank you, Heather. Thank you, Audrey, for bringing Heather to us. We're going to move on to some more specifics now and talk about the clinical trials that are going on at St George's. And Tihana Bicanic has recorded a talk for us, summarising the different clinical trials going on at St George's, which Heather alluded to. So, Audrey, if you've got those lined up, let's hear from Tihana.
Sure, coming up.
Hello, my name is Tihana Bicanic, reader and consultant in infectious diseases at St George's Hospital, and I'm going to talk to you today about COVID-19 clinical trials at St George's. So, the widely publicised Oxford-led recovery trial was the largest trial in the UK, for which St George's was also an early participant. It opened in March 19th in the UK, and we opened here at St George's on the 29th of March. It is an adaptive design, randomised controlled trials, that is, arms can be added and dropped as the trial goes. And it's very simple to conduct, with very simple outcome measures and data collection tools, meaning that many hospitals were able to join it very quickly, which has made it the largest global randomized controlled trial for COVID-19 patients. Eligible patients were initially adult, but also pregnant women and children were later added, who were in hospital with SARS coronavirus 2 infection. And these were randomized to one of 5 treatment arms, either no additional treatment, otherwise known as standard of care, lopinavir, ritonavir, or Kaletra, an HIV drug, the steroid dexamethasone at moderate doses, 6 milligrams a day, the antimalarial hydroxychloroquine, and the antibiotic azithromycin, all given for 10 days or until hospital discharge, whichever was the soonest. And the primary outcome measure was all-cause mortality at 28 days, with a number of other secondary outcome measures, including the need for mechanical ventilation. You can see here that being such a simple trial and being endorsed by the Chief Medical Officer and NIHR, it very quickly rolled out to 176 active sites. And has to date enrolled just over 12,000 participants, of whom 80 were enrolled at St George's Hospital. You can see here that peak enrolment, the graph on the right, coincided with the peak of COVID-19 in April in the UK, and at that time, 3 weeks from trial start, they were enrolling between 400 and 500 patients a day, and currently those numbers are more like 30 to 40 per day. The trial has gone on to add additional stages. First of all, in April, there was a second randomization added for a subset of patients with persistently low oxygen, hypoxia, and signs of inflammation with a CRP, C-reactive protein, above or equal to 75. And that randomized patients further beyond the antiviral first stage into either tocilizumab, an anti-IL-6 inhibitor, or standard of care. And then later on, in the 30th of May, the option to randomize people to the addition of convalescent plasma or not in the first arm was also added and rolled out to a number of sites. This is a summary table from one of our investigators' meetings showing the demographic data on patients, almost 11,000 patients in the trial. You can see here that 2/3 of patients, almost 2/3, are men, as in many COVID studies, with a mean age of 66. And they were enrolled very quickly, on average 2 days from hospitalization. About a quarter of the cohort did not require oxygen. The largest group, almost 2/3, were on supplemental oxygen, and 14% were either ventilated or requiring ECMO, a heart and lung bypass procedure for the sickest patients. And the comorbidities were, as described for COVID-19, with just over a quarter having diabetes and heart disease, and 22% with chronic lung disease. This is a snapshot of some mortality data in these 11,000 patients, not by arm, but just by age strata. You can see here that the percentage mortality at 4 weeks increased with advancing decades of age, was higher in men, was higher in those requiring oxygen or ventilation, with 22% of patients in UK hospital on oxygen having a 4 week, being dead at 4 weeks, and just over a third on ventilation. And you can see here that again, mortality was higher in those with comorbidities. The first arm to stop enrolling was the hydroxychloroquine arm. This was subject to much controversy, and the week before, indeed, there was a paper published and later retracted in the Lancet, an analysis of deaths and toxicity of patients receiving hydroxychloroquine, which seemed to suggest harm. However, the recovery trial initially continued with hydroxychloroquine, but then decided that they had enrolled enough patients to undertake an analysis, and recruitment was then stopped, and findings were released on the 5th of June, which showed no clinical benefit of hydroxychloroquine over standard of care, with over 1,500 patients enrolled, and no significant difference in their survival to 28 days. The next very much publicized results of the recovery trial, and leading to the most significant advance in COVID-19 treatment to date, was the dexamethasone, the steroid arm, and enrollment stopped because sufficient numbers were enrolled, and results were announced. Enrollment stopped on the 8th of June, and results were announced the following week. And you can see here that from the graphs on the left, overall, mortality was lower in the dexamethasone arm, significantly lowered, but when this is broken down by disease severity strata, you can see that in fact those receiving dexamethasone seem to have a higher mortality, although it was just a trend, or not even a trend, not significant. However, the curves were flipped for those receiving oxygen, where there was a 20% reduced risk of dying, and then a 35% in those receiving a mechanical ventilation. And this was, of course, hugely exciting news, and this cheap and widely available drug could immediately be implemented worldwide, including in low and middle income countries. The next arm, the lopinavir-ritonavir arm, was dropped on the 29th of June, again due to sufficient enrollment and showing no clinical benefit against standard of care, again in over 1,500 patients. So just to summarize, this study has enrolled almost 12,000 participants. You can see that the second randomization, the tocilizumab arm, these are data from as of the end of June, have recruited almost 800 patients, it being now the largest trial of tocilizumab to date, and over 100 patients have been enrolled into the convalescent plasma arm. The next drug I want to talk about is another widely publicized drug called remdesivir, made by Gilead Sciences, a nucleotide analog and inhibitor of the RNA polymerase of numerous viruses, including Ebola and the coronaviruses, MERS and SARS, with some promising in vitro data and macaque model data before starting human clinical trials. we did our best to try and join one of the existing clinical trials of remdesivir when coronavirus exploded at St George's, but because there were sufficient UK sites, we were offered an expanded access program, a compassionate access with some clinical data entry. And the drug was at that time restricted to adults who were mechanically ventilated and did not have renal or liver failure and didn't require any pressor support to maintain their blood pressure. It was a 10-day course of intravenous treatment, and with the help of the nurses in the clinical research facility, we had to do detailed clinical and safety data entry daily to day 28, and we managed to enroll 4 patients, of whom 3 sadly died, although these were all patients, very sick patients on intensive care, and the deaths were due to be COVID-19 related, and there weren't very many significant side effects. Following this, there was publication in the New England Journal of the ACTT1, the Adaptive COVID Treatment Trial, led by investigators at the National Institutes of Health in the States. This was a trial at 60 global sites, including 5 in the UK, and the projected numbers were over 1,000 randomized between remdesivir or placebo. This was not a mortality endpoint trial, but the primary outcome in this study that's smaller than the recovery trial was actually time to recovery, defined as either being discharged alive or not needing medical support or oxygen. And this trial went on for 2 months and was then stopped early by the Data Monitoring Committee on April 19, after just under 400 patients had recovered. And the reason it was stopped, and it again was much publicized by Anthony Fauci, appearing before the trial was published, announced the results in the White House, was that remdesivir significantly shortened the time to recovery, and median of 11 versus 15 days to placebo. And also importantly, at the early 2-week endpoint, there was a significant reduction in mortality, with just over 7% dead versus just under 12% in the placebo arm. So this then led to the FDA issuing conditional approval for use of the drug in patients on oxygen. And the important thing about being on oxygen is when you broke the cohorts down again into illness severity, a bit like the dexamethasone arm, the most significant difference was really in patients receiving oxygen, with a recovery rate ratio of 1.47 and a hazard of death of 0.22. This was in contrast, however, to dexamethasone in the ventilated patients. There was no significant effect on recovery or survival with patients on remdesivir. So this then led to the UK implementing the Early Access to Medicine scheme, whereby teenagers and adults with COVID-19 who were either on oxygen or early on in non-invasive ventilation but not mechanically ventilated could receive a 5-day course of the drug. However, in the last couple of weeks, this program again has been stopped because the European Commission has now conditionally approved Gilead's remdesivir. The cost is not yet known in the UK, but it will be commissioned centrally for the NHS, and the US cost of a 5-day course will be over $3,000 as opposed to £5 for a treatment course of dexamethasone. Of course, SARS coronavirus, there's the viral replication stage, and then the second immune phase, whereby there is this cytokine storm induced by the virus by activation of various intracellular signaling pathways through binding to the TNF-alpha and IL-6 receptors through the JAK-STAT signaling pathways, leading to a release of numerous pro-inflammatory mediators, notably TNF-alpha and IL-6, and a number of drugs have been proposed and are in clinical trials blocking various aspects, notably tocilizumab, an IL-6 receptor antagonist, as well as baricitinib, a JAK-STAT pathway inhibitor, which I'll mention a bit more about further. Tocilizumab came to the attention of a range of clinicians and clinical academics at St. George's, listed here across different specialties, due to some promising preliminary findings from a report in China. And they very quickly drew up a protocol and received trust approval for the compassionate use of the drug in a subset of patients which were either on the ward but needed oxygen or intubated on intensive care, but also had this sign suggestive of hyperinflammation or a cytokine storm. That is a rising C-reactive protein, raised D-dimers, a high ferritin and high lactate dehydrogenase. And these patients received either a single or 2 doses of tocilizumab. And over the course of just 9 days, 11 patients were treated, 7 of whom were ventilated, and they were 3 days from hospital admission. And you can see from this table here, for those who know about the clinical parameters, these are extremely high inflammatory markers. Now, tocilizumab had a dramatic effect within 2 to 3 days in switching off the hyperinflammation, as can be seen here, with a drop in CRP in all patients and a later rise in just a single patient attributed to bacterial sepsis. This is just a graph showing that for those who were not on ventilation, oxygen requirements decreased rapidly over the course of a week, and indeed patients were able to be a number of the patients came off oxygen and were discharged. And in fact, looking at this 8-point WHO scale ranging from death to discharge, you can see that in this very small cohort, uncontrolled cohort of 11 patients, just 2 patients died and the others were improved and all went on to discharge. So this was a small case series targeted and selected for markers of hyperinflammation, and indeed in May there were a further 6 treated, of whom 5 survived. Those 11 patients were published in a pharmacology journal led by Emma Baker, and have added to some retrospective smaller series in the literature, and then more recently promising results from an Italian retrospective cohort of over 500 patients, in which again, this is a non-randomized selected study, but tocilizumab treatment was associated with a reduced combined risk of ventilation or death. Ongoing industry-sponsored studies are the Covacta study by Roche, as well as the Oxford-led recovery trial, as I mentioned earlier, which we await the results of these eagerly, as well as the other anti-IL-6 inhibitors, sirilimab, with ongoing studies led by Sanofi. So the way forward in terms of new studies would be to capture patients at this important stage 1 to 2 of illness, that is at the stage where rapid viral replication elicits this pronounced immunological report, and select these patients early at high risk of complications to combine treatment with an antiviral such as remdesivir and an immunomodulator such as either steroids, or there are ongoing trials, Remdacta, sponsored by Roche, using remdesivir plus tocilizumab, or the second phase of the ACTT2 trial, which is adding remdesivir to the JAK inhibitor, baricitinib. And indeed, here at St. George's, we have recently opened 2 studies, one of which is industry-sponsored but led in the UK by Nidhi-Sofat, called COVI Barrier, which randomizes patients to the oral agent baricitinib, which is a Janus kinase inhibitor used in rheumatoid arthritis and inflammatory bowel disease, but also showing promising antiviral activity as well as immunomodulatory. And there is the Tactic R study, which is an investigator-led study from Cambridge, which is another adaptive study comparing, including a standard of care arm, and then comparing this to an anti-complement inhibitor, anti-C5 inhibitor, ravulizumab, baricitinib, and with the potential to add additional arms, and with 3-month follow-up. So in summary, it's been a period of intense activity, and it's been an enormous team effort between nurses in the clinical research facility shown here, principal investigators both within the Institute of Infection and Immunity and in the hospital, and sub-investigators across specialties, as well as pharmacy, emergency, pediatrics, and obstetrics. Thank you for listening.
Thank you, Tihana. That's a fantastic roundup. Can I just share a screen for a second, Audrey? Is that, do I have permission to do that?
Yes, you do. Go ahead.
Great, thanks. I just wanted to share, can you see the recovery screen? Recovery webpage on your screen?
Yes, we can.
Yeah, I just thought it was worth highlighting that the recovery trial that Tihana talked about is an ongoing treatment trial. And I guess one of the things that's rather unique about COVID, because of the speed at which it's all happening, is the way in which results are being released real time. And we don't have to wait for the full analysis of all the results and final publications, although obviously people are working to peer-reviewed papers in due course. But in order to speed up the dissemination results and application of outcomes, sites like or research organizations like the Recovery Trial are publishing their ongoing results as they go. So I'll post this as a web link. But if you want to know where we are with recovery, so for example, if you did want to know what recovery found about hydroxychloroquine, you go to recoverytrial.net results, hit the hydroxychloroquine box, and there's a statement: no clinical benefit in the use of hydroxychloroquine in hospitalized patients with COVID-19. There's one or two people probably who do with reading that, but I won't say any more than that. And then it's the link to the journal article, and the same for the lopinavir ritonavir arm, which we used to call Kaletra. It's an old HIV drug that's been repurposed, and no clinical benefit there. And then the dexamethasone with the results in several languages, and a link to the pre-publication and the preliminary report. So that's a useful website. So let me unshare. And let me share conversation. If you do want to look at that, that's the link I've just posted in the chat. And I just want to say very briefly, I mean, I think St George's has hit above its weight and made a fantastic achievement in contributing in these clinical trials. And I think there are a few things that Tihana referred to, but perhaps worth highlighting. Why could we do this, and how could we do this? Well, I think firstly, because we had a pre-existing clinical research structure. Secondly, that we could repurpose that to COVID and stop doing a lot of the trials we were doing at the time. And there's a huge shift in work from in the research office and all the allied clinical research facility and all the allied teams to switch from doing, I don't know, hypertension clinical studies to doing COVID research studies. So that pre-existing structure that's been set up over years with years of investment and expertise, being able to reallocate that. We also have pre-existing expertise in clinical trials. So people at Tihana, who's familiar with doing clinical trials in cryptococcal meningitis, could then use that expertise in the field of COVID. And I think there's dedication, engagement, and particularly engagement of the health service staff in participating in trials, where there's great enthusiasm for that. So the co-location, the relationships that we had with the clinical staff at St George's, I think made a huge contribution. So St George's, I think, found itself very well placed to contribute what it could to the COVID research response because of these pre-existing structures, pre-existing expertise, the ability to move fast to reallocate resources, and the dedication, enthusiasm, and hard work of a lot of key people. to move on, we've also done a lot of studies in diagnostics, and Tim Planche has been leading on this. Another pre-recorded talk, so I hope Audrey's ready with her finger on the button. We're going to hear from Tim Planche about diagnostic studies at St George's.
All right, coming right up.
Oh, and thanks very much for inviting me to the Jennerosity talk. Sorry I can't be there, but let's get along talking about diagnostic studies at St George's. Now, when coronavirus hit the UK in March this year, there was a lot to be done. Not only were patients coming in, but we needed to start researching the disease. And actually, I think these diagnostic studies give you a very good idea of just how quickly we were able to work and how efficiently we were able to work between the university and the hospital to get diagnostic studies up and started. I'll present mainly two studies, so the DART study and the London COVID study, and these are huge team efforts which I've been lucky enough to take part with, and just a big thanks to everyone who's taken part in them. If you look at the other studies that have gone on, now I've put the diagnostic studies at the top here, but there's a large number of other mainly therapeutic studies going on. If we go back to early in the illness in March this year, we were seeing a huge increase in number of cases. We'd had some early data from China, and we'd been able to get together a PCR we were running in the diagnostic lab, and that was able to show cases, but we didn't have that much information about the long-term follow-up and the diagnostics of the illness. So really we were thinking roughly like this in the broad terms about an infectious disease. You have an exposure, you get it and you incubate for a variable period of time, probably 2 to 7 days in the case of COVID. You're then asymptomatic during that period. You then develop symptoms. At some point during your incubation period, you will develop detectable virus. That'll carry on while you've got symptoms, and after you get better, maybe there'll be a bit of virus. You've got then develop an immune response, which you can detect as well through antibodies or other methods. And that develops either when you're symptomatic or whether you're asymptomatic, and certainly is there in recovery. In addition to this, there could be asymptomatic patients who never develop symptoms. If you look at, again, the types of immune response, I'll just put a reminder at the bottom right. You've got two types of broad immune response in humans. One is a humoral, where B cells become plasma cells that produce antibodies that then destroy the invading bacterium or virus. Or you've got a T cell cellular response, where T cells destroy infected cells. I think another thing before we start is the complexity of coronaviruses. They're relatively simple viruses, but there's still a fair number of proteins on them. So they're an RNA virus, and you can see that in the middle. That's coated in a nuclear capsid protein. There's an envelope around them, which has spike protein, also an envelope protein in it, and a membrane glycoprotein. So relatively simple viruses, but still with a number of antigens which antibodies may react to. First study I'll talk about is London COVID. This is a study from PHE that we were able to participate in. Thanks very much to the team. You can see sneaking down the corridor there. This enrolled about 1,000 participants, mainly from staff members across London. We at St George's recruited 535 of them. And the way this study worked was members of staff were invited to become a part of the study, and every 2 weeks we take an antibody test. This would allow us to look at the seroprevalence and the development of antibodies over time. We have tested the serum on the Mologic test you'll see about later, but also on the Roche and the Abbott platform. Initial data showed that around 20% of staff, or about 100 out of 535, have been positive for the virus, which is in keeping with a lot of places elsewhere around London. And we're still waiting to analyse some of the data, looking at what happens over time and comparing platforms. The data will come out about that soon. second and possibly larger group of studies are studies that are done with Mologic and Liverpool University. This was a result of a grant put in by Prof. Krishna along with Mologic, who are the lead participants, and Liverpool University. And this has developed antibody and antigen tests for COVID-19 for low and middle income settings. Thanks to the team now, they're on the bottom left there. So this was a DFID Wellcome funded grant, and this came out of the need to develop these diagnostics. The CIs are myself and Prof. Krishna, and you can see the speed that we got approval of this study. In March 2020, we were pretty much ready to go. One of the first times is excess diagnostic material. So effectively, anyone who comes into hospital with COVID is having a number of other blood tests, so whether they're a full blood count or a liver test, these are sent to the main lab. And normally these are thrown away after a couple of days. But what we did here was able to intercept them, get the samples, anonymize them, attach a bit of clinical data to them, and be able to use them in these studies. We were able to longitudinally follow up patients who come in and get repeat blood samples on them, and use these for cellular or antibody testing. We report here from between March 29th and May the 22nd, but we have data that these studies are ongoing. So here's a summary of it. Excess diagnostic material was taken, they were anonymized. Now, when you're developing a diagnostic at the start, you don't quite know how it's going to work and need to have a lot of prototypes. So what we were able to do is work through a number of prototypes. For one of the forms, the ELISA, there were not that many prototypes, so which antibody you're going to use, which antigen you're going to detect, and what concentrations they're in. But still, that's 5 to 10 samples. But for the small lateral flow devices that are a bit like pregnancy tests, there were 40, 50 different devices that had to go through. So this ability to have a large number of serum samples was really very, very helpful. There was a second work package, or work package 2. Here, we recruited patients into a study. Now, unfortunately, by the time we were able to recruit into this study, and this had the advantage of taking extra samples, both from throat and nose, but also blood samples, COVID was really waning. We were only able to recruit 5 patients with COVID and about 15 controls into the study. But it's ready in case, unfortunately, we happen to have a second wave. Now, to give you some results, firstly, the ELISA enzyme linked immunoassay. You can see it's a 96-well plate format, and basically, if antibody is present in the serum, you get a blue color forming. And you can see the 96-well plate there. What you can see here is firstly how good it is detecting the antibody in patients. So if the patient has antibody, how likely are we to detect it? Now, initially, this is done by you find someone who's got a proven virus with a PCR, and then measure the amount of time either after they've had their PCR done or after their symptoms started. And here you can see the theme which is common for all these tests is in that the longer you wait after you have a positive test or symptoms start, the more likely you are to detect the antibody. So if you detect less than 10 days after you've had symptoms, about 75% have detectable antibody, and this rises to 100% at 40 days. Be a little bit careful of the number at 40 days because it's a slightly smaller number, but actually you've got a good detection rate up to later. And these tests are comparable to the big assays in Roche and Abbott, which we're using. They're a little bit less suited for the large labs that you might have in Britain, which are fully automated. These can be done by hand or done on machines, but given the price of these, they may be a very good option for low and middle income settings. If you look at the specificity, now this is how likely you are to have a false positive or how likely you are to definitely detect a negative. Now, again, this shows an area that we were able to help very rapidly working between the university and the hospital. In the diagnostic department, we store routinely anyone who has a serology test for 2 years. We just store their serum in case we need to look at it again. What we were able to do was to get examples of important interfering substances, so whether they were other coronaviruses, whether they were rheumatoid factor, or whether they were other viruses such as flu or illnesses such as malaria, to see if they'd interfere. because you do get cross reactivity with a number of viral tests. And what you can see here is we were able to find around 400 samples. This includes samples from elsewhere, but you can see that the confounded non-coronavirus samples, seasonal coronaviruses, and the autoantibodies samples were all gained from the stores. And thanks to Danny, Irene, and Linda for finding all these samples. And what you can see here is an overall specificity of 97%, and again, very, very high. Next to the lateral flow, now these are like pregnancy devices. You can see them on the bottom right, and these give a series of bands, one for IgM, one for IgG, one for IgA, and you can measure the color against the script there, and a little cartoon of how you get gold particles combining with the lateral flow to give you your lines. These are cheap to produce and take about 10 minutes. So actually very, very potentially useful in low settings. If we look at the sensitivity here, again, you've got the common theme that this sensitivity increases over time, so your likelihood of being antibody positive increases over time. And again, this goes up from around 70–80% at the start to, again, with smaller numbers, but up to 95 to 100% after several days. If we look at the specificity, again, this is about 97%. This is again using this panel of quite stringent serum samples in order to detect this. If we look at the clinical findings now, what you can see is that a number of clinical things were found. If we compared patients who didn't seroconvert with those who did, so those who developed antibody that didn't, those who developed antibody tended to be older. Younger patients were more likely not to seroconvert. BMI, so how much you weighed, was higher among those who seroconverted, developed antibody that didn't, and those with comorbidities were more likely to seroconvert than those that didn't. It wasn't affected by ITU admission or symptomatic disease, or patients who happened to die, but it was also affected by C-reactive protein. So a higher C-reactive protein, you're more ill, the higher your COVID antibody response. These are, by the way, normalized optical densities. You take an optical density and normalize it against its control. If you look at the time, the normalized optical density over time after a swab was taken, at the top you can see the actual serial antibody tests for all the 100 or so patients in this. A little bit difficult to read. At the bottom graph you can see something slightly more sorted out, and you can see in blue those who happen to seroconvert, and in red those who didn't seroconvert at all. And as you can see, because we're taking XX diagnostic material, we're not following everyone up. We don't have follow-up to the end for everyone, but you can see that antibody tests appear to be relatively well maintained up to around 2 months after the illness. You can see that around 8% did not seroconvert, but as we don't have follow-up on all of these, if you take follow-up after 30 days, only 2% had it seroconverted. So we've got a figure of around between 2 and 8% not seroconverting. If we now look at normalized graphs, you can see that we're reaching a peak of antibody levels at around 20 days. So you're plateauing off at around 20 days. Now, to summarize the studies that we have so far, we've been able to get, in a very, very short period of time, working between university and the trust and across with private partners, 3 CE-marked diagnostic kits, which have been submitted to the WHO and are looking for production to go into use across sub-Saharan Africa. Clinically, looking at the use of these tests, we've validated, as many others have, that the longer you wait, the higher your sensitivity is, and you reach a plateau around 19 days. There are, however, around 2 to 8% of patients that won't seroconvert and develop IgG with the Mologic ELISA assay. which was to spike 2 and to nuclear capsid. And we did appear to have sustained antibody levels at least for a couple of months. And also disease severity. So the more severe your disease, the more likely you are to develop antibodies. Now, there's still a lot of work to be done. We've got to continue developing these assays and also develop some PCRs or antigen tests with quantum DX, and also continue with Mologic. We need to increase the sample size to see if we can answer more, and just look at the follow-up to see what happens to antibody levels. We can look at other more important things in terms of understanding the immune response, so titrations, neutralization, Western blots, and just continue this follow-up. So we're looking for further grants and further funding to carry on with this important data set we have. This was a large group of patients, and thank you to the patients, but also thank you to these huge numbers of staff, both from the university and from the trust. So up the top right, members of staff from the London COVID, and down at the bottom, the DART study. Thank you very much indeed. Oh, and thanks very much for inviting me to the Jennerosity talk. Sorry, I
Notice we were going to hear it all over again in case you missed it first time. Thanks, Audrey, for pressing the buttons, and thank you, Tim, in absentia, for very nice summary. And just one thing I wanted to flag on that. I'm not sure how much Tim flagged it really, but really one eye very much on lower middle income countries, and producing technologies that are not just good for high-tech labs in well-resourced countries, but simple devices that can be used in lower middle income countries as well. And then finally, we have a real talk, I think. Except I've lost my program again. Sorry. System problems today all around. Our fund with Robin Parsons, who I think is here in person. Robin, are you there?
Hello, yes, I am. I'm here in person. Can you hear me?
Robin, fantastic. Can you, sorry, I know you're from the Clinical Research Facility, but I can't introduce you more than that. Who are you? And would you like to introduce yourself and give us your talk? Thank you.
Yes, of course. Let me just...
Have you got a camera?
I have got a camera. I was just about to share my screen.
Lovely. We can see it.
You can see it. Fantastic. So my name's Robin, and
You're still
I
in
am
preview mode. I don't know if you want to go on presentation mode. If you hit the...
So my name's Robin, and I don't quite know how to work Teams.
If you go slideshow at the bottom.
Oh, you mean preview mode on this? Yes, yeah.
Go to slideshow in PowerPoint, and then we can see the whole screen. That's great, thanks.
That's fine. Okay. So my name's Robin. I'm a research midwife, and actually I work in the Vaccine Institute with the Paediatric Infectious Diseases team, normally working on maternal vaccination studies, but of course now everything has turned into COVID studies. And Kirsty just asked me to do a presentation on peri-COVID, which is a study that aims to understand COVID-19 in pregnant women and their babies. So I thought I would kind of initially go over what we know about COVID-19 in pregnancy so far, for anybody who perhaps doesn't have an obstetric background. So there's currently no evidence that pregnant women are more likely to be severely unwell, need admission to intensive care, or die from the illness than non-pregnant adults, which is really good, but is also a little bit counterintuitive to what we would expect from kind of other respiratory illnesses in pregnancy. Pregnancy is an immunosuppressive state, and there's also changes to lung capacity and volume. So when women get things like influenza, often they are sicker than the average adult. Most women who experience COVID-19 will get kind of mild symptoms that are in line with what we would expect from the general population: the fever, shortness of breath, and the cough. And we're fairly confident that we can say this because in March, UCOS, which is the UK obstetrics surveillance system, launched a registry for all pregnant women admitted to UK hospitals with confirmed COVID-19. It's the largest population-based cohort of pregnant women, and it has now been joined by several other registry studies such as pan-COVID or inter-COVID, which are looking at, again, COVID in pregnancy, but with slightly less strict or wider inclusion and exclusion criteria. However, although the UCOS report forms the basis of the of the current guidance from the RCOGs, that's the Royal College of Obstetricians and Gynecologists. Evidence is still quite limited, and it's particularly limited to do with modes of transmission. And despite the fact that most women will get mild symptoms, there are still consequences. So from this UCOS cohort, of the women that gave birth, 27% had preterm births, and 47% of those were iatrogenic for maternal compromise. Although there was no evidence that fetal growth restriction is a consequence of COVID-19, it could still be possible because it was in effect with SARS. Really sadly, there were 5 maternal deaths from COVID-19 in UCOS reports. With regards to vertical transmission, so that transmission from mum to baby, there is a suggestion that it might be possible. So a recent report has demonstrated that there was a high SARS-CoV-2 viral load in the placenta, and that had manifestations with the neonate. From an interim report from UCOS, 6 babies did have positive COVID swabs within 12 hours of birth, and it's unfortunately unclear whether that was transmitted in utero or if that was transmitted postnatally. And 2 reports have published evidence showing IgM for SARS-CoV-2 in neonatal serum at birth. Can I just check if you can still hear me?
Yes, we
Yes.
can.
Yeah,
Yes,
fine.
all good.
Sorry.
We can hear and see.
Good. Perfect. Okay. So these are some of the kind of the physical, the manifestations of COVID. But I think as a midwife and for women, what's been really important is that impact on maternity services. So routine antenatal surveillance really is the backbone of good obstetric care, and it really contributes to the low rates of mortality and morbidity that we see in the UK. And that is the simple, perhaps quite mundane things. It's things like going to the midwife, having your checkup, having your urine checked for bacteria, which may cause miscarriage or stillbirth. We're looking at measuring women's symphysis fundal height. So that's measuring the size of the uterus to check for those babies that are falling behind on the growth curve, maybe struggling with their growth inside the womb. Looking at blood pressure to look for preeclampsia, which again has an impact on maternal health. In the face of COVID-19, maternity services really rapidly reorganised. So face-to-face midwifery appointments were really reduced for women and staff to reduce their risk of catching COVID. But that means that a woman may not meet a midwife until she's 16 weeks pregnant instead of 8 weeks pregnant before. And she may only see the midwife 5 times instead of 8 in her pregnancy. So it's reducing that surveillance, which has an impact on maternity. Additional services such as home birth was suspended, so women's choice was also restricted, and birthing partners were limited and restricted again to reduce that risk of transmission. But there were lots of reports in the media, lots of women being very upset about this, and that will have really impacted their time as a family and impacted their pregnancy and their mental health in their pregnancy. There's also some evidence that lots of women left London. Especially at the beginning of the pandemic, so some hospitals reported kind of 10% fewer births, and that has implications for women who perhaps slipped through the net, that needed to be seen at tertiary centres, that transferred their care and might have missed appointments and scans. At St George's, analysis of our pre and post pandemic period showed a statistically significant increase in stillbirths in the pandemic period, So none of those stillbirths were attributed to COVID. Instead, they're attributed to perhaps a reducing care. So perhaps women are so scared of catching COVID because they don't know the effects it will have on their baby that they don't go to triage if their baby's not moving, which we know is a sign that babies can be suffering. They may sit at home and think it's okay. I would kind of be keen to point out that they did only analyse 2 time periods. It was retrospective, and we are a tertiary centre at St George's, so we often see high-risk cases, but it's something to kind of bear in mind. There's also anecdotal evidence reporting kind of an uptake in abortion services during the pandemic. Again, women are particularly scared. They don't know the effect that COVID-19 will have on their unborn baby. Could it be something like Zika virus? And as midwives, we're not able to answer those questions yet. Shielding of viruses was really unclear in the beginning. Women didn't know if they needed a shield. They didn't know if they're entitled to a shield. They don't have any evidence to take to their employer to say, you need to protect me. I think it's also going to be really relevant coming into this period of economic uncertainty. Pregnant women will be at the front line for redundancies, and so it's important that they have evidence they can take. And we can also adapt our services to try and mitigate those impacts once we know. So this is the purpose of peri-COVID, so we can understand COVID-19 infection in pregnant women and their babies. It's a collaboration between Public Health England and ESCO, and its primary objective is to determine the risk of COVID-19 infection in newborn infants born to mothers with confirmed COVID-19 and potential routes of transmission. To be involved in the study, women didn't have to have kind of a current infection with COVID-19. It was just at any point in their pregnancy, they'd had a positive swab, and that they were over 24 weeks pregnant when they were admitted to the study. It has some secondary objectives as well, which is to determine the presence of SARS-CoV-2 in various clinical specimens, so things like the nasopharyngeal secretions of both mother and baby, urine, stool, breast milk, placental swabs, and amniotic fluid as well. It's a national surveillance study, got ethical approval from PhD Research Ethics. It's multi-site, so we've had samples from kind of across the country. And it will also share data with UCOS, so that's Obstetric Surveillance System, and PAN-COVID, which is another COVID registry. In terms of the scientific analysis, there'll be an RT-PCR run on all of the swab samples. For the serology, there'll be an ELISA on blood samples and also breast milk samples, and there will be whole genome sequencing as well. And that's it. Thank you very much.
Thank you, Robin. That was a really interesting talk. And I think one of the things you really highlighted on there, sorry, I'm not going to talk for long because we're over time, but was what I call collateral damage. I organised a teaching day for the students last week on COVID, and we had a talk there which I asked one of the local GPs to do, and we called it collateral damage, because it's very easy to focus on the morbidity and mortality of COVID itself, and certainly we've seen a very saddening number of deaths from COVID, but there's also collateral damage within the health system. So there's an increase in death and morbidity from other diseases because of COVID. And this is one of the things we saw in the Ebola outbreak in West Africa in 2014, is there's an increased number of maternal deaths because maternity services just fell apart during the Ebola outbreak there. Now, we've had nothing like that in terms of services falling apart, although some countries got pretty close, I think, and some hospitals got pretty close to all their services being so overwhelmed with COVID that we can't manage other problems. And certainly cancer care, I think, has suffered hugely during COVID because of having to cancel appointments. So what you might call collateral damage is a huge issue with the whole COVID pandemic, and children not getting their vaccinations and so on and so forth. The list goes on, but I think it's important when you think about COVID to think beyond COVID and all the other impacts of that. Which brings you back to the COVID Action Fund, and that's what it's all about. And so I'm going to say thank you to all the speakers. On the chat, there's a comment from Richard about the Covacta trial. There aren't any questions, and only one of the speakers is here, so I'm not sure we can do questions and answers. So I'm going to draw the input part of the Jennerosity Seminar to a close and hand back to Melanie, who's going to take us to the riotous social part of the seminar or event.
Yes, thank you, Derek. I forgot to mention, we put the Just Giving link on the chat. So if you want to donate, it's there. And I want to a big thank you to Derek for hosting, and also for Audrey Tay for technical help. Really appreciate that. Thank you, Audrey, and also everyone who has
Thanks,
spoken.
Audrey. Sorry, yes. I forgot to say that.
No problem. I'm just pushing buttons. I'm just going to stop recording, okay?
Yes, that's fine.
We won't want to record our riotous part.
Okay.